great pleasure to be here. Thanks to Linda and Tom for inviting me to discuss this topic that's near and dear to me. Title of the talk is the Omega-3 Index from Biomarker to Risk Marker to Risk Factor. And I'll explain what some of that all means in a moment. But we'll go to the next slide, I think. That's interesting. My slide won't advance. I need to move it. And hopefully that's visible. So I thought I would at least start with the big picture of why I would include a topic.
Oh, you'll need to reshare your screen. It dropped. Oh, there you go. Great.
Next slide. That's not the slide I. We good now? I think I've got. Okay, great. Now I just I wanted to just step back a moment and ask why we'd include a topic like the Omega-3 Index for an S&P conference. And the basic idea is once consumers learn that via a blood test that they are low or deficient in omega-3 fatty acids, then they should be more motivated to fix that problem. And that should drive them to eat more fish. I think hopefully that's obvious connecting the dots, but that's the reason we're talking about omega-3 blood test biomarkers. Okay. The trouble is I can't advance my slide when I'm on this picture. This is not, maybe it is. Okay. Hopefully you can see this. So to begin with, what is the Omega-3 Index? Many of you are familiar with this concept. It's been around now for about 16 years. But the Omega-3 Index is a measure of the amount of omega-3 EPA DHA that's in red blood cell membranes. It's measured and expressed as a percent of total fatty acids. So if this is a cutaway of the membrane, these are the phospholipids that make the outer and the inner membrane of all cells. Actually, red blood cells are a good example of it. And in this cartoon, all the hanging down things are fatty acids. The red ones are omega-3s and the black ones are not omega-3. So we have in this little cartoon 64 fatty acids. 3 of them are EPA or DHA. So that makes an omega-3 index. 3 out of 64 is 4.6%. And so that would be what we would call the omega-3 index from the person from whom this blood cell was taken. This is a very typical omega-3 level for Western countries. It's about half of what it is in Japan. The original idea when we proposed the omega-3 index back in 2004 was that we would pick a number that would be a target for good health, optimal health. And in those days, what we had was cardiovascular disease, actually mortality, death from cardiovascular disease. And we put together the data we had at the time and came up with an average of 8% would be seems to be what the data said would be a target omega-3 index that one should seek to achieve to reduce risk for cardiovascular disease. And that has, I think, held up over the years. Now this is our scale for what we think the omega-3 levels should be. People who are down here under the 4%, we typically recommend trying to get about 1,500 milligrams of EPA and DHA a day to increase that 4% up to the 8%. If you're in this intermediate zone, like 4 to 6, between 4 and 8%, roughly 750 milligrams. As you can see, these are intakes that are quite easy to do with seafood on a daily basis. And then if 8% to 12%, that's our target range. And if you're in that range, you're doing fine. You don't need to increase your intake. So let's first of all talk about the omega-3 index, a biomarker of omega-3 intake. I have to give a shout out to Susan Carlson, who I think is the first person to ever use red blood cell omega-3 levels as a marker of a biomarker of how much omega-3 is in the body, and she published this way back in '86. And the idea caught on in the cardiovascular world about 10 years later in the first study, and that used red cell omega-3 by David Siskovic. So Susan really, I think, deserves credit for the idea. Why do we say it's a valid biomarker for intake? This is data that we generated and published last year. And what this looks at is data from our laboratory measuring the Omega-3 index on this scale, and data from about 3,500 people for whom we've analyzed their blood. And the important thing to look at here, I think, is the blue bars. The blue bars show how the Omega-3 index goes up with each increasing reported intake of fish. So from no fish per week up to 3 times per week of, this is really baked or non-fried fish. So this would be kind of oily fish. And there's a very nice stepwise relationship. The more fish eaten, the more omega-3 eaten, the higher the omega-3 index. And that makes it a biomarker of intake because it responds appropriately to increasing intake. The red bars are simply the same categories of fish intake, but in people who report taking omega-3 supplements. And in general, of course, this goes up as well. The people who are on a supplement are usually about 2 omega-3 units higher than those who are not on a supplement. I would note that the only group that actually exceeds 8% of omega-3 index was the people who are eating fish 3 times a week, and who are report taking an omega-3 supplement. So it seems to be it's unusual to be able to get that high, but that's what it takes. AHA, American Heart Association goals, recommended fish intake, 1 to 2 fish meals a week would probably only get you an omega-3 index in the area of about 5 to 6%. So we don't think the American Heart Association is quite up to snuff on what their recommendations are. Now let's move from the question of a biomarker of intake to a risk marker. It's a very different thing. A risk marker is a marker that you measure in the blood that tells you something about a disease process or a risk for a disease. And the omega-3 index fits this category. I'm going to put quite a busy slide up here, and I will not go through this in detail, but this was guidelines for what's called criteria for evaluating a novel risk marker for cardiovascular risk. And this is an outline that one has to think through when you're looking to see if your blood-based biomarker, whatever it is, whether it's blood cholesterol or blood glucose for diabetes, or in this case, omega-3 fatty acids, does it actually fit the criteria for being a risk marker? And so the criterion are down here. Does the marker differ between subjects with and without the outcome? The outcome here is cardiovascular disease. Yes. And I'm going to talk a little bit about this as we go on. Does the marker predict development of future outcomes? Yes. Does the marker add predictive information to standard risk markers? That's a good question. If your marker is a risk, actually predicts risk, but it doesn't do it any better than the standard stuff we've already got, what's the point? So it's got to improve upon risk prediction, and there's still evidence we have to gather in that regard. Does the risk marker change predicted risk sufficiently to change recommended therapy? Absolutely. There's no question that's the case. In other words, raising omega-3 levels is very safe and very cheap. We can do it by eating more food, and that's worthy of a recommendation. Does the risk marker, use of the risk marker, improve clinical outcomes in clinical trials? Yes, it does. And does the marker improve clinical outcomes sufficiently to justify the additional cost and of treatment? Of course, yes, it does. The testing is fairly cheap, and treating it, of course, is just eating more fish or taking supplements. That's a quick rundown. I want to just give you the next step in that is going from omega-3 as a risk marker to a risk factor. A risk factor is a factor that you can change and change your risk. It's one thing. A risk marker might be age for cardiovascular disease, or sex, or higher risk. by and large, men are at higher risk for cardiovascular disease than women. Risk factors are things that you can change. And we think that's the important point here. You can modify your risk by changing a risk factor. And so here we have another set of criteria from Hill, published 1965. So these go way back. And this is questions: does a risk marker actually show that it's causal? It's part of the causation of the disease. If it's not part of the causation, changing it's not going to make any difference. If it is part of the causal pathway, then changing it can make a difference and reduce risk for a disease. And I'm not going to go through all these, but the omega-3s do satisfy all of these criteria. Except for this last one, it's not specific for cardiovascular disease. Omega-3 levels are really associated with risk for quite a wide variety of chronic diseases. So in this category, that's not a bad thing. It's a good thing. It's just that it doesn't satisfy this particular criteria. So let me look at a few of some data to help understand this. So the question on the left, does the novel marker, here in this case Omega-3 Index, differ between people who have a disease and who don't have the disease, subjects with and without the outcome? And the answer is yes. Do people who have heart disease have a lower Omega-3 index than people who don't? And this is data from now about 2008, where we looked at the Omega-3 index in people who were admitted to the hospital with acute coronary syndrome. So that is the disease. The cases were people who were the same age, race, and sex who were not patients with coronary disease. And we can see that the odds of actually having coronary disease were about 90%, 70% less in people who had the highest Omega-3 index. So there's a situation where we do have the marker is different in people with and without the disease. Another point: does the marker predict development of future outcomes in prospective cohort studies? Yes, it does. Here we published this 2-3 years ago, a meta-analysis of 10 studies worldwide where we looked at risk for fatal coronary heart disease as a function of the Omega-3 index. And in these studies, if you go from the lowest category, 4%, up to the highest category, 8%, there's a 35% lower risk of fatal coronary disease in people who have higher Omega-3 index. So that fits that category. This paper was referred to by Tom earlier. This was the one that was published today from the group at GoEd, Aldo Bernasconi, first author. I just want to show you some of the data. This is the latest meta-analysis looking at the effects of dose on cardiovascular outcomes. And this is what Aldo and his group showed, that and the question here is, does changing exposure to the factor, in other words, raising the Omega-3 index, does it change the incidence of disease? And yes, it does, meaning giving Omega-3 fatty acids, which raises the Omega-3 index every time, does change the incidence of disease. And this is a meta-analysis. Now, for example, myocardial infarction in 24 different studies and over 130,000 people. The people who were given Omega-3 fatty acids compared to placebo had about a 10% statistically significant reduced risk for that particular outcome, MI. And you can see all these different cardiovascular outcomes were significantly reduced by the Omega-3 fatty acids. So the latest meta-analysis does show Omega-3s do reduce risk. That's great. How about other things besides just cardiovascular disease? This is data that we looked at in a large group of women, 6,500 postmenopausal women. We followed for about 15 years of follow-up after measuring their Omega-3, and we found that a Omega-3 index of over 8 was associated with a 31% lower risk of death from any cause, so total mortality, not just cardiovascular disease, but death from anything. And this has been confirmed in other studies. So to quickly summarize, the Omega-3 index is a validated biomarker of Omega-3 intake. It's certainly better than a dietary questionnaire getting at what your Omega-3 levels are, and it's more stable than a plasma measure of Omega-3. It satisfies 6 of the 7 American Heart Association criteria as a risk marker. We do need to study incremental value better. And it does satisfy 6 of the 7 Hill criteria as a causal risk factor. It fails to be specific for heart disease, but as I said, that's not a problem. Let me conclude here that higher omega-3 index levels are clearly associated with better health. Primary way to raise the omega-3 index is by eating more oily fish, salmon, herring, salmon, or sardines, etc. Albacore tuna are good examples. And of course, omega-3 capsules will also raise the omega-3 index. And so that would be the end.